Sure.
Yeah, okay. Thank you. Just a minute, sir. I will indicate. Okay, we are live on YouTube, and with all your permission, we are starting out to this session. A very good afternoon and a warm welcome to one and all present in this session. I am Debulina from Neonates side. We are very much privileged to be a part of this webinar as a digital partner. So now with all of you, I'm going to share a short glimpse of Neonates. Thank you so much, all the doctors, for your patience. You all are invited to visit our website, which is www.clonate.com. So now, without further delay, I'd like to over the session to Dr. Rana Patel to take over from here. Over to you, sir.
Thank you so much. So very good afternoon to all of you. Greetings from NNF Gujarat. On behalf of NNF Gujarat, I, Dr. Ronak Patel, welcome one and all in today's learning in neonatal Pathshala. Today we have our guest experts, two guest experts from Rajasthan. I will introduce. One is Dr. Divakar, Dr. Dheeraj Divakar. He is from Udaipur, and he has done DM Neonatology from Jipmar, Pondicherry, and currently is a head of neonatology at Radiant Children Hospital, Udaipur. Welcome, Dr. Dheeraj. And
thank you, Dr.
Another guest we have is Dr. Mohit Vora. He has done DNB Pediatrics along with a fellowship in Pediatric Gastroenterology, Hepatology, and Nutrition. And he has done fellowship in Advanced Pediatric Endoscopy and Colonoscopy as well. Currently, he is working as a Pediatric Gastroenterologist and Hepatologist at Sashakt Childcare Gastro and Liver Center at Jaipur. Welcome, Dr. Mohit.
Thank you, Dr. Ronak. Thank you so much.
I also welcome our advisor, Dr. Somsekhar sir, and our secretary, Dr. Prashant Karya, Dr. Kunal. And today we have a presenter with us, Dr. Ketul Chaudhary. He is doing his fellowship in neonatology. Welcome you all. So without wasting much time, I will hand over the session to Dr. Ketul.
Thank you. Back to Ketul.
Dr. Ketul, can you share the? Yes. Okay.
Yes, sir. Visible, huh?
Yes, visible and audible, both.
Good afternoon to everyone. Myself, Dr. Ketul. I am presenting a seminar on necrotizing enterocolitis, which is a most common illness in the NICU. Okay. Our today's seminar outline will be background of the NEC, what are the incidents of the NEC, and risk factor between risk factor in the preterm and term babies, and what are the pathogenesis of the NEC, what are the clinical features of the NEC, and investigations, and what are the differential diagnosis. Betterly, we can say NEC reductionism, and how to prevent the NEC, and management aspect, and what are the complications and prognosis of the necrotizing enterocolitis. What is necrotizing enterocolitis? Necrotizing means death of the tissue. Entero means it refers to the small intestine, and colo means large intestine, and itis means inflammation. So it is a inflammation of the small intestine and large intestine, and it is defined as a inflammatory condition of the gut characterized by the gastrointestinal and systematic signs and symptoms, including the feed intolerance in terms of the repeated gastric aspirations, greenish aspirates, vomiting, abdominal distension, lethargy, temperature instability, abdominal tenderness, occult or gross blood per rectum, and apnea, and poor peripheral perfusion and shock. In 1965, Muzrahi and colleagues first time defined the necrotizing enterocolitis to describe a clinical syndrome consisting of the vomiting, abdominal distension, shock, and intestinal hemorrhage and perforation. In 1978, Bale and colleagues classified a necrotizing enterocolitis into 3 stages based on the severity of the clinical presentation and recommend treatment strategies for the NEC. NEC involves the infection and inflammation both that causes destruction of the bowel or part of the bowel. NEC can involve all layers of the bowel, and it leads to even eventually the NEC totalis. What is incidence? NEC is a predominantly disease of the prematurity in less than 32 weeks and less than 1.5 kg. It is 85% present in the preterm babies, whereas in term baby it is present in 15% cases, mostly associated with the ischemia, cardiac disease, and gastroschisis. Overall incidence is 6 to 10% in infants less than 1.5 kg, and as we can see this in birth weight, lower the birth weight, higher the chances of the NEC. So any incidence of the NEC is inversely proportional to the gestational age, as in 500 gram to 750 gram incidence of NEC is 12%, whereas in 1.25 kg to 1.5 kg incidence is 3%, and overall mortality is higher with the lower gestational age. What are the risk factors for the necrotizing enterocolitis? Mostly it is associated with the prematurity. Prematurity is it is the mostly present in almost all cases of the NEC. Hypoxia, other factors are hypoxia, sepsis, formula feeding, hemodynamically significant PDA and related drugs like indomethacin, ibuprofen, and some incidents associated with the umbilical arterial catheterization, blood transfusion, mostly associated with the extent transfusion, use of the H2 blocker like ranitidine, empirical broad spectrum antibiotic use in less than for more than 5 days, and maternal risk factors like absent or reverse end diastolic flow, Doppler and antenatally, and IUGR babies, chorioamnionitis, HIV, abruptio, and genetic polymorphism or lack of the antenatal steroid, and smoking. This is a comparison between the preterm neonates and full-term neonates risk factors. In preterm neonates, it is mostly associated with the gastrointestinal immaturity, immature host defense mechanism, aggressive antenatal feeding, PDA and its management associated with the indomethacin therapy and ibuprofen, and hypoxic injury in the birth asphyxia, or presence of the bacteria within the GI lumen associated with the dysbiosis, and some epidemic cases associated with the NICU overcrowding. In full-term neonates, it is mostly associated with the congenital heart disease, some coexisting factors like small bowel atresia associated with the Down syndrome, some and most commonly associated with the gastroschisis, polycythemia, and compromised GI oxygenation flow in the mesenteric blood flow associated with the SVT, extent transfusion, and perinatal stress events, and aggressive enteral feeding. Pathology. Pathogenesis of the NEC is multifactorial, and it is mostly associated with the, there are few eyes here, immaturity of the GI tract, immature host immunological system, intestinal microbiome alteration, also called dysbiosis, infant formula milk, and inflammation playing a key role in the NEC. And most common site of involvement is the distal small intestine and proximal large intestine. And what are the pathological hallmarks? It is a coagulative necrosis and inflammation and bacterial overgrowth. This is the pathological hallmark of the NEC. What is pathogenesis of the NEC? As we have seen, NEC is a multifactorial disease resulting from the complex interaction between the immaturity of the GI tract, mucosal injury, and bacterial imbalances. We can say that it is an altered harmful inflammatory response to the intestinal antigens. And intestinal immaturity playing a key role in view of it is a in immature GI tract, there is a increased permeability of the intestine, decreased motility of the GI, thin mucous layer and low IgA level, and lack of the regulatory adaptation in the preterm baby. And microbes have an important role in the development of NAC. In Betel becomes termed as a dysbiosis, in which there is a decreased microbial diversity and increase in the pathogenic bacteria, which replace the good bacteria, which is helpful in the preterm baby. And there is a excessive and inappropriate intestinal inflammatory response, which is a key factor inciting the role in the NAC, and which leads to failure to down regulate the toll-like receptor 4, which leads to inflammatory injury. There is the chart of showing how pathogenesis of the NAC occur. Infant formula feeding, prematurity, and dysbiosis leads to the permeability, increased permeability of the GI tract, loss of the mucosal layer, less IgA, and which leads to the penetration of the bacterial, which leads to the lipopolysaccharides and other factors, which leads to production of the toll-like receptor 4 activation, which also attract the chemokine and neutrophil activation, which ultimately produce the inflammatory cascade, which release a PAF-like factor, TNF alpha, which increase intestinal permeability, and which leads to intestinal tissue injury and necrosis, and ultimately shock and necrosis. And in last, it leads to the transmural necrosis and septic and shock. What are the clinical features? Mostly it presents with the non-specific systematic signs like increased episodes of the apnea or bradycardia, temperature instability, lethargic or irritability with the poor feeding, increase in the respiratory distress, pallor, in the lab finding acidosis there, hyperglycemia is there, and thrombocytopenia is there, neutropenia is there, and in last there is a cardiac compromise like the poor perfusion, shock, and oliguria. And most predominantly it present as a abdominal signs. Initially it present as a feed intolerance like the increase in the gastric aspirate, vomiting, abdominal distension, and later part there is a abdominal tenderness there, or blood in the stool, peritonitis, abdominal wall, edema, erythema, and ascites, and the occasionally sometimes there is a diarrhea is there. This is a Bell staging of NAC, which is based on the systematic signs, abdominal signs, and radiological signs. It is divided in the 3 stages. First stage is suspected NAC. Second stage is the definite NAC, and third stage is advanced NAC.
Dr. Ketul, sorry to interrupt.
Yes, sir.
You have just discussed pathogenesis. So, would you please highlight why preterms are at more risk compared to term babies? As you have already mentioned in pathogenesis, would you please clearly elaborate what are the main factors that predispose preterm more compared to term?
Yes, sir. In term babies, there is a in preterm babies there is a more use of antibiotic is there, more infant formula feeding is there. There is a less administration of the mother's milk is there, and suspected sepsis is there. Infection rate is more in the preterm baby is there. So it is most associated with the immaturity of the more present in the immature baby than in the term babies there.
Something about host defense mechanisms?
Yes, sir. It is the most important mechanism is there, as I have explained previously. It is a immaturity of the host immune response, which is a inciding event for the NEC.
Okay. Go ahead, please.
Yes, sir.
Okay, just a second. I would like to interrupt here. Ketul, you are doing wonderful job. First of all, I would like to appreciate. Till now, you have presented very good. So this is a very interesting discussion which is going on. Many a times, Ketul, you have mentioned that the gut immaturity in premature babies.
Yes, sir.
So what exactly do you mean by gut immaturity in premature babies? How is that gut in premature baby differ from the gut in the term infant? Can you just give me a quick difference between the two?
Yes, sir. As I have mentioned, there is a less, there is a thin layer of the mucosa is there. Increased penetration is there.
Right.
Lack of the tight junction is there, and lack of the IgA is there, and
Right.
immature host immunological response is there.
So what are all these like less tight junctions, low mucus or thin mucus layer, less of IgA secretory antibodies? So, and what does all this do? What exactly, what is it causing basically when all this is there?
All this leads to the mucosal injury, sir.
Which leads to a mucosal injury because it increases to the translocation of bacteria because of increased permeability from gut to the vessels. That is the important, step which is involving in the systemic infection in such babies. So there's a translocation of bacteria from gut. All those factors you mentioned are absolutely correct, but all these factors are leading to translocation of bacteria from gut to the blood vessels responsible for systemic manifestations. Can you just quickly name what all microorganisms present in premature and what all microorganisms present in term? What is the difference that 2-3 microorganisms specifically when you talk about the predominant taxas, predominant colonies of these microorganisms in mature babies, the term babies, and the preterm babies?
In preterm baby, it is a E. coli and Klebsiella and Enterobacteria is more predominantly present in the preterm gut, sir.
Right. So how does it differentiate from the term babies?
In term babies, there is a bifidobacterium is there.
Absolutely. Very good. So it is Bifidobacterium brevis, it is bacteroids and Streptococcus. These are the three major bacteria which are predominating the taxas in the term baby gut.
Yes.
And how are these bacteria responsible? Do you know how are these bacteria important? These microorganisms are important because they are responsible for secreting a polysaccharide, and that polysaccharide is responsible for the maturation of immune system, and as well as also it is looking after your that TL4 receptors you mentioned.
Yes, sir.
The regulation of those TL4 receptors. So these three bacteria, they top the list of the taxas which are present in the premature babies, and that is how it is being helpful, right?
Yes, sir.
Right. Okay. Go ahead. Ketu.
Okay, sir. First stage is suspected NEC. It is divided in the three portions: a systematic sign, abdominal sign, radiographic sign. It is a non-specific sign. We can say it is associated. It is mostly we can say it is a feed intolerance, or it is we can say sepsis-like presentation. In systematic signs, temperature, there will be a temperature instability is there, apnea, bradycardia, lethargy is there. In abdominal sign, there is an increased gastric residuals, abdominal distensions, and vomiting is there, and occult blood is there, which is not that specific to the NEC. And radiographical signs like normal or some intestinal dilatation and mild ileus is there. In 1B, there is in abdominal sign, there is a grossly bloody stool is there. In second stage, there is a 2A, it is called a definite mildly ill. In systematic sign is similarly temperature instability, apnea, bradycardia, lethargy. In abdominal sign, there is a decrease or absent bowel sounds with or without abdominal tenderness. And in radiographical sign, there is a intestinal dilatation, ileus, and pneumatosis intestinal, which is a pathognomic of the NEC. In 2B, it is a moderately ill. there is some systematic sign included, like lab parameters like a metabolic acidosis and mild thrombocytopenia. In 2A means absent bowel sign plus abdominal tenderness plus there is abdominal cellulitis is there, or right lower quadrant mass is there, or absent bowel sounds. And in radiographical signs, there is a abdominal cellulitis, or there is a mass is there. And in the third stage, 3A, which is called a DIC, we can say. In there is a hypotension is there, shock is there, bradycardia, severe apnea, and required respiratory requirement, and severely metabolic acidosis. Neutropenia is there. There is a no urine there, and abdominal signs. We can say that there is a peritonitis mark, abdominal tenderness is there, abdominal distension is there, abdominal wall erythema is there, and in 3B there is a radiological sign. There is a pneumoperitoneum, which viscous perforation is there. What are the investigations for the NEC? There are laboratory investigations like CBC with the peripheral smears, which shows the anemia, neutropenia, and thrombocytopenia, and hemolytic changes in the smear. And if this changes like a neutropenia and thrombocytopenia is early written within 24 hours, that indicates a good prognosis in the NEC. And there are certain markers like the CRP, other markers like the procalcitonin, fecal protactin, serum amyloid A, and there are certain others. And electrolytes, which is most commonly like a persistent hyponatremia, and also with hyperkalemia, which is associated with the anuria. And blood gas analysis, most commonly metabolic acidosis, hypoxia will be there, and hypercarbia. And these three, thrombocytopenia, persistent hyponatremia, and metabolic acidosis, this is a triad for biochemical triad of the NEC. And there will be, in the third stage, there will be a coagulation, there will be a bleeding will be there. So PT, APTT, and a platelets count. And blood culture must be sent because there is a concurrent sepsis rate will be almost 40% there. And stool examination for the blood or occult blood, and stool culture for the Clostridium and Klebsiella. Imaging modalities, most commonly everybody using is the X-ray. In supine AP abdomen and left lateral decubitus, X-ray are essential for the diagnosis. And if we are suspecting the perforation, then standing X-ray will be required. And what are the X-ray findings? There will be a dilated bowel loops, or in serial X-ray there will be a fixed bowel loops with air fluid levels or there. Or there will be a pneumatosis intestinalis, which is also get the intravisual gas. This is a radiological hallmark of the NEC, which present as a crescent, and it is a pneumatosis is caused by gas within the bowel wall, which is by the bacteria, and may seen as a linear, or which is seen as the crescent. Or if it is a circular, then it will be a subserosal, or there will be a soft bubble appearance if there is a submucosal gas. There is also a porter-venal gas will be there in the X-ray, or a pneumoperitoneum, which is there will be a two sign, regular sign, which is showing the pneumoperitoneum or football sign like appearance, and there will be a gasless abdomen in case of ascites. This is the X-ray of the NEC. So this is the portal venous gas is there. There is a crescent is there showing the pneumatosis, and subbubble appearance is there. There is a pneumoperitoneum seeing in the X-ray. There is other modality like USG abdomen Doppler recently used in the NEC, and it is showing 100% sensitivity for the free and absent blood flow, showing the necrotic gut compared with the 40% sensitivity by the X-ray. So more commonly it is using in the NICU nowadays. This modality can be used to assess the bowel wall viability by color Doppler and as well as the bowel wall thickness, perfusion by the Doppler, and fluid collection for the with the presence of a particular debris. Pneumatosis, intestinalis will be there. Portal venous gas will also be seen by the USG. This is the USG abdomen and Doppler finding. First one A is the diagram showing the normal gut mucosa, normal bowel wall, showing the normal Doppler in the NEC patient. Second image is showing the showing the initial stages of the NEC, showing the dilatation of the bowel wall and increase in the blood flow. This is called hyperemia. And in Doppler, there is a increase in the blood flow showing in the second image. Third image, there is a blood flow is reduced and bowel thickness is the same. Increase in the bowel wall and reduce in the blood flow. In the fourth slide, image, there is a reduced blood flow, severely reduced blood flow, and there is a reduction in the bowel size, which is showing almost near to perforation. And fifth image is showing the severely reduced bowel wall and no blood flow in the bowel wall, which is showing imminent perforation.
So what does it tell us? It tells us that USG is the modality, best modality for diagnosis, Ketul? Or is it still how would you like to approach? Like if given a choice between X-ray and USG, should we do X-ray in a baby who you're suspecting NEC or directly go to USG abdomen?
No, sir. First, because there is a USG is not every time available in the in the NICU. So first approach should be the X-ray. If there is a clinically we are found that it is a NEC looks like, but X-ray not showing the feature. So ESG will be very helpful to differentiate the. There is an increase the initial findings like reduced blood gas flow, increase in the bowel wall motility. Bowel wall thickness will be there. So I think X-ray first.
So the message should be very clear that initially we'll have to go for an X-ray because we have to be cost effective first of all, and availability definitely is the second probability, which may or may not be there USG. So if the clinically scenario fits for NEC, definitely we should go for an X-ray abdomen. Just telling us many of the signs which we were already seeing when we were in early times. We were not using USG. Nowadays USG has come up and started showing some with 100% accuracy. But again, the cost effectiveness is also very important. So yes, X-ray is a very important tool, cannot be neglected, followed by USG if required. Right, go ahead.
Absolutely correct, Dr. Mohit. Still, X-ray would be the preferable modality of investigation, and USG is assisting tool. As we have seen, USG has the USG probe is nowadays replacing the stethoscope in NICUs, and it is the coming tool. But still, X-ray would be the gold standard, assisted by USG. Yeah.
Absolutely.
Go ahead, please.
So what are the differential diagnoses of the NEC? Better we can say NEC reductionism. Differential diagnosis of the NEC includes the other conditions, which includes abdominal distension, rectal bleeding, and perforation. So this includes the spontaneous intestinal perforation, which is the most common and also important in view of the prognosis factor. And feed intolerance, which is most commonly associated with the preterm babies. There is a septic ileus, which is also very common in the preterm babies. Malrotation with the midgut volvulus, interstitial infectious enterocolitis, allergic colitis like EMPA. This is a difference between the spontaneous intestinal perforation versus the NEC. It is SIP is a disease of the first week of the life, and median age of presentation will be within 7 days. Whereas in the NEC, it is a disease after first week, and mean age of presentation will be around the 12 to 15 days. So it is present after significant feeding. And SIP, there will be no such like there will be a significant feeding. And
so how the presentation time of NEC is related to gestational age, Dr. Ketul?
sorry, sir.
The timing of presentation of NEC, how it is
Yes.
related to gestational age?
Yes, sir. More the preterm, more the NEC is the, it is inversely related to the PMA, sir. So
Yeah.
mean age of presentation will be around 12 to 15 days, and mean week of PMA will be 30 to 32 weeks, sir.
Lower the gestational age,
Yes, sir.
later it will manifest.
Yes, sir. Same.
Right?
Yes.
Yeah.
Yes.
Please
Okay.
go ahead.
In SIP, there is mucosa will be spared and the rest layer will be necrosis. And NEC, there will be a ore layer necrosis. And most important finding is here, after exploratory laparotomy, there will be a proximal gut area healthy and other than the perforation. Whereas in NEC, there will be a total necrosis in the proximal area to the perforation. And SIP will be more associated with the PDA and its treatment. And NEC, there will be not that such significant. And in SIP, there will be an abdominal distension with the fluid discoloration, and it present up to even in the groin and genital area in the scrotum. And NEC, there will be a abdominal distension with the abdominal erythema, and the crepitus will be there, and induration will be there. And SIP is it is a less severe and less mortality, and NEC is a more severe and more mortality. And SIP is a single perforation will be there. In NEC, there will be a multiple perforation will be there. And SIP, there is a good prognosis. NEC, there will be a worse prognosis. So differential diagnosis, pneumonia and sepsis, it is associated with the septic ileus, no gas in the rectal portion. So basically, it is a paralyzed gut. And there will be no abdominal tenderness and discoloration as seen in the NEC. It is a important finding in the NEC. And malrotation with the midgut volvulus, there will it is a most commonly diagnosed mostly with the USG and CT abdomen, and during even sometime during the exploratory laparotomy. Infectious enterocolitis, it must be suspected in the cases of the diarrhea and lack of the other systematic and abdominal signs in the NEC. And cow milk protein energy associated with the severe allergic colitis present with blood in the stool, abdominal distension. But a patient will be very appearing and normal X-ray and lab findings. Feed intolerance, which is the most common differential diagnosis in the first stage of the NEC. It is most commonly associated with the feed advancement in the premature babies. It is presented at the vomiting, bilious gastric aspirate, and abdominal distension on associated with the increase in the feeding. And it is difficult to differentiate from the early NEC. And transfusion associated NEC, it is present within the 48 hours of the transfusion, and mostly associated with the AB blood group, and have a fulminant course in the NICU. It is mostly associated with the antigen present in the enterocytes, and which leads to the inflammatory cascade and leads to the NEC. So early, there is a prevention is the we can say that prevention is the best cure, and it is fully suited to the NEC because it is a nightmare of the NEC, nightmare of the any pediatrician or neonatologist. There is a 3 lines of the prevention, NEC prevention. First is recommended measures based on the good to moderate evidence. Second is the suggested measures with the limited evidence, and strategies not to recommended for the routine wear. First one, recommended measures based on the good to moderate evidence. There are 2 evidence which is a very good to moderate to prevent the NEC. First is the antenatal corticosteroids. There is a Cochrane review regarding the SCH in 2017, which includes the 30 trial of the almost 8,000 women and 8,000 of the infants. And it clearly showed the 54% reduction in the NEC with the other benefits in terms of the death, RDS, PVL, and sepsis. And the second one is the human milk feeding, mother's own milk feeding, even pasteurized donor human milk is also good for the preterm babies, which is a good evidence regarding the prevention of the NEC. And human milk feeding, there is a trial regarding the human milk feeding versus formula feeding, and donor human milk versus formula feeding, and there is a clearly showed the less incidence of the NEC with the mother's own milk, and in even donor human milk, there is a reduction in the NEC 1.7% versus 6.6% in the formula feeding babies. And there is a certain beneficial factors like it lowers the gastric pH, which reduce the inflammatory cascade, and there is it enhances the intestinal motility as well as the matures the intestinal tract, and it promotes the immunological maturation system with the provision of the secretory IgA, lactoferrin, oligosaccharides.
As you suggested here, that go to the slide, last slide.
Yes, sir.
You suggested that this beneficial factor of breast milk is that lowers the gastric pH.
Yes, sir.
I just remember one thing. When you were talking initially, you mentioned something about H2 blockers, that they are associated with NEC.
Yes, sir.
Can you tell me how? What exactly is the mechanism?
Sorry, sir, I don't know exact mechanism of the, but
actually, because the why I am talking this here, because as you mentioned that this breastfeed decreases, lowers the gastric pH, and which is helping in decreasing the incidence of NEC. H2 blockers, what they are going to do? They are going to increase the intestinal pH.
yes.
When they increase the intestinal pH, they basically promotes the growth of a particular bacteria, which is known as protobacteria.
Yes.
So all these protobacteria and these microbiota, they are grown more in this alkaline pH, that is increased pH in the intestine, and they react with the intestinal epithelial cells and produces lots of leukocytes and calprotectin, which are responsible for causing inflammation of the intestine, and hence this inflammation leads to one of a factor leading to NEC. So just that, gastric pH coincidentally struck me. That is why I brought this point. I hope it is clear.
Yes, sir. Thank you, sir.
Okay, go ahead.
There are some suggested measures with the limited evidence, like standardized feeding protocols in terms of the minimal enteral nutrition, also called as the trophic feeding, and some standard feeding guidelines, and which have a proven benefits in decreasing incidence of the NEC. There is a study regarding it includes the 15 studies and 18,000 infants included in the study, and which showed clearly showed the benefits with the standard feeding guidelines. And there are some studies regarding the advancement of the feeds and the timing of the initiation of the feeds, which don't change the rates of the NEC. There is a SHIP trial regarding the speed of increase in the milk feeding trial, in which there is a which includes the less than 32 weeks of babies and less than 1.5 kg of patient, and divided into two groups: slow increment and fast increment in terms versus 18 ml per kg per day versus 30 ml per kg per day, and there is a no clear NEC rate change in the seen in the fast increment of the feeding. And there is a ADAPT trial in the SGA babies, which shows the early feeding versus the late feeding, early feeding in sense of 48 within 48 hours, and the late feeding versus means after 6 days of 6 days of the life, and which clearly there will be a no change in the rates of the NEC. And there is also a trial regarding the bolus feeding versus continuous feeding. There will be a no change in the NEC. There is a also avoidance of the prolonged antibiotic use for more than 5 days, which leads to the dysbiosis of the gut microbiota, and leads to the prolonged which leads to the NEC. There are certain other measures with limited evidence, like the avoidance of the H2 blocker, like sir explained. Gastric acidity may play a role in the preventing cascade of the infectious and inflammatory events leading to the NEC. And there is a severe anemia and transfusion, which is called TANA. And there are some reports regarding the transfusion is associated with the NEC. But their causal association will not be found. But there is a regimen regarding the prevention of the transfusion associated NEC. In this method, there is a withholding of the feeding for before transfusion for 2 hours, and during transfusion 4 hours, and after transfusion 4 hours, withholding of the feeding is there. It is a method to prevent the TANA. In
transfusion, is there any strong recommendation for withholding feed during transfusion?
No, sir. There is no clear recommendation regarding that, but there are certain experimental, or we can say there is a expert views regarding that. There is
it vary from unit to unit.
Yes, sir. Yes.
Some unit they do not even keep the baby NBM during transfusion. Some units, like they can decrease the volume sometime.
Yes,
but
sir.
They are still continuing with the feeding. Some unit, as you have mentioned, keep NBM for 2 hours prior to the transfusion, 4 hours, 2 + 4 + 4. Some keep during transfusion NBM, and then immediately after transfusion finishes they start. So still it is a point where a lot of research and some more adequately powered RCTs are needed. So it definitely vary from unit to unit. So some units are comfortable with not withholding the feed. Some units even keep for 12 hours NBM also while giving transfusion. So this practice vary definitely from one center to another center.
Yes,
so, and it should not be a take-home message of withholding feed. It should not be a take-home message for everybody who's listening, because as sir said that it varies from unit to unit. It is absolutely correct. We at our hospital are giving feeding. We don't withhold for 2 hours and nothing like that, 2 feeds. And we don't have any bad experience in over decades, last decade. So I think this is all right. This is not a criteria right now to say that withhold feeding for 2 + 2 + 4 hours. Okay, so go ahead.
Yes, sir. In transfusion purpose, there will be a requirement of the fresh, irradiated and leuko-reduced PCB should be to minimize the incidence of the NEC. There is some suggested method with the limited evidence, and the most controversial topic, enterally fed probiotics. In a Cochrane review, which includes the meta-analysis of the 30 RCTs and 14 observational studies, which showed the significant reduction in the severe NEC in terms of the stage 2 or more, with the relative risk of the 0.57. But they also showed it is not that good evidence in terms, because some studies involve the which were very small, and there is a poor methodology in the methods. So there after that there will be 2 major trials occur in the in good terms of methodology and large population, like probiotics in the preterm baby study, which is popularly known as the PIPS trial in the UK, and Preterms trial in the Australia under Sanjay Patel sir, together covering almost 2,500 babies, and they clearly showed there is no demonstrated any reduction in terms of the death, sepsis, or the NEC. In that study, they include the it is a multi-center trial with Bifidobacterium brevi BBG 001 strain, with which compared with the controls in terms of the sucrose, and there is no reduction in the risk of the death. In probiotics, it clearly study shows there in less than 28 weeks babies, there is no clear benefit in the less than 28 weeks of baby. And single strain versus the multiple strain, there will be a benefit with the multiple strains. in some studies, and some there are the two probiotics mostly covering the bifidobacterium and lactobacillus GG, and most single strain is good is bifidobacterium brevi, and in lactobacillus there will be a lactobacillus acidophilus is good in reduction of the NEC.
Absolutely true. I think this is a very important slide. Go back, because this is a very important take-home message here. What is the role of a probiotics in prevention of NEC? Because again, in spite of so many multiple trials, so many meta-analysis, still we say that this is a gray zone. Why? Because in spite of so many trials, we say the trials are still few. In spite of so many data, we still say that the outcome data is still very less. So to predict or to say, give one conclusive line, which is still missing. So it is, undergoing studies which come up every day, but the crux which we need to remember, whether you give, say, multiple strains or you give a single strain, whether do you give probiotic or you do not give probiotic in prevention of NEC, the underlying point to remember is that till now, it says that it decreases the severity of NEC. It doesn't prevent NEC. I should be very clear. Whatever all the crux of all the studies says that decreases the severity of NEC, if at all. Let me put it in inverted commas, if at all. And it decreases mortality. These are the two things which all the probiotics, all these studies are telling us till now. And definitely, yes, lots of studies have been done with Bifidobacterium breve, which is on the top list, followed by your Lactobacillus GG. So these are the two most commonly studied probiotics. So that's why most commonly we have studies of these two probiotics. So the name of these two comes more prominent in the list whenever we are talking about. So it's a very important message to be taken that it is not preventing NEC as per now, but it decreases the severity and decreases the mortality, whether you are using the combined strain or you are using a single strain. And that is that. Go ahead, Ketan.
As you have started the slide saying that it is most controversial, and
yes,
as Dr. Mohit also mentioned,
yes,
the one important part that it's quality control. It
Absolutely.
Doesn't come under FDA, right?
Yes,
So whatever means how much, what strain is there, what sterility is maintained while preparation of that strain, these all things are not tightly regulated. So that is also one point which goes against the routine recommendation for routine
Absolutely.
uses of probiotics.
Absolutely.
Right?
The most important caution is that it requires a strict temperature control, which is not there in our country, first of all, to use these probiotics. So it is to be even stored in a strict temperature control, which we are not following. So Sir is saying is absolutely correct. So quality control is a very important aspect which cannot be neglected. Absolutely true.
So still in the West and US, UK, 55 to 60% of the units they are using it for preventive NEC. Not all the units across the globe also, if you see the units which are having higher incidence of NEC, they have started routine uses of prophylactic probiotics, but not, I think it's not generalized yet. Yes, please go ahead.
One more thing I want to add here, sir. I forget to mention there. There is a ISAPGAN criteria. It not strongly recommend, but it it gives a conditional recommendation regarding the use of the probiotics with some standard safety measures. There will be no clear benefits with the use of the probiotics, and some suggested measures with the limited evidence. NEC care bundle elements. There are 4 elements in the NEC care bundle. First is regarding the following the standardized enteral feeding guidelines, as we have seen previously. There is a early promotion of and expression of the breast milk and use of the mother's own milk for the feeding of the baby, and ongoing support of the expression and breastfeeding. And for these, standardize the clean approach towards the preparation of the feeding using a standard aseptic non-touch technique. And goal of the NEC care bundle should be prepare a mother for within 10 days and discharge at the 10 days of life. And in NEC kit bundle, they standardized feeding guideline in 3 group. First one is the red group, and second is the yellow group, and third one is the blue group. Red group is includes the which are babies is the less than 28 weeks and less than 1 kg. And second group is yellow group, which includes the baby of 28 to 32 weeks old, and which weight of 1 to 1.5 kg. And blue group includes the more than 1.5 kg and more than 32 weeks of old. And strategy is not recommended for the routine care by the American Academy of Pediatrics, which recommend not to routinely use a probiotic in prevention of the NEC. Second is the not to use oral immunoglobulin to prevent the NEC in the preterm, and recommend not to use nutritional supplements, including the lactoferrin and arginine. And there is 2 trials regarding the lactoferrin. There is a Cochrane review which showing the benefit with the use of the lactoferrin. But it is showing it is a least strong evidence, because there is a poor methodology and a small numbers of the patient. So after that, there is a trial which is called as the ELFIN, enteral lactoferrin in infants in neonatology, in neonates, which includes the lactoferrin in preterm babies, and which shows no benefit to the which prevents the NEC. And there is also another study which showed that lactoferrin with probiotic reduce the incidence of the late onset sepsis and NEC, but there is a more trial needed because of the small number of the size and poor methodology. There is a role of the arginine in the prevention of the NEC. There is a 3 trials regarding that and covering the 285 neonates, showing a significant reduction of NEC of risk ratio of 0.38. But there is a number is very small for to say that it is a great evidence. But more trials are needed regarding that. So lines of management. Prevention is the best for the NEC, but if there is a NEC occurred, then there are 2 types of the medical management. First is medical management, which is for the all cases of the NEC, and second is the surgical management, which is for specific cases. Medical management, it is first is keep the nil by mouth baby for 5 to 14 days according to the stage of the NEC, and gastric decompression of the baby every 4 hourly or every 2 hourly as required. And there is a replacement of the aspirate with the 0.45 NS to prevent the electrolyte imbalances. And TPN must be required in the particularly in the stage 2 or 3 stage of the NEC. And is there any UVC or USC, then remove it. And respiratory support in the form of the CPAP or ventilator to prevent the repeated apnea or bradycardia. And circulatory support in the, if there is a features of the shock, and give bolus with the NS, and as soon as required the inotrope, and blood pressure monitoring continuously, and do blood gas, and if there will be metabolic acidosis and electrolyte imbalances, which should be corrected. Blood culture must be sent because it is associated with almost 40% of the sepsis, and to start the broad spectrum antibiotic as per the NICU protocol, and with specifically anaerobic cover, mostly using the ampicillin and gentamicin with metronidazole. Sometimes it is required piperacillin and meropenem and vancomycin sometimes. And fungal cover is essential for the NEC stage 2 or 3 to prolong the broad in view of the prolonged broad spectrum antibiotic uses. pain control management and minimal handling should be there, and maintain hematocrit and give PCV, FFP and platelets if there is evidence of the bleeding or low platelets there. And there is a certain criteria regarding the giving of the PCV transfusion. If there is a PCV, if there is a hematocrit less than 35, and there is a requirement of more than 35% of FiO2 or ventilation requirement, then give PCV. Or if there is a less than 35% FiO2 requirement in CPAP or in oxygen or high flow baby, then give PCV. And if there is a hemodynamically stable, but there is a symptoms of the anemia, then give PCV less than 20% of the hematocrit. Renal function monitoring there is one of the most common presentation in the late stage of the NEC, in where there is a no urine output will be there. So urine output monitoring is very essential. Urea and creatinine and serum electrolytes, most specifically sodium and potassium, in view of the hyperkalemia and hyponatremia, and fluid management must be done according to the renal function of the baby. And serial X required for the fixed loops of the NEC, and abdominal girth monitoring. And early pediatric surgeon involvement is the most necessary for the NEC, because if there is a advanced NEC, then it will leads to more cutting of the portion of the NEC, which leads to short bowel syndrome. So better early pediatric surgeon involvement is most necessary thing. Surgical management, there is absolute indication for the surgery is the pneumoperitoneum. And some are other relative indications, like the lack of the response to the medical management in form of the severe persistent metabolic acidosis and or severe thrombocytopenia, suggestive of the presence of the necrotic bowel, and persistent of the fixed loop on the serial X-ray, and persistent of the mass in the right hypochondrium, and constantly elevated serial infection marker in like a CRP, procalcitonin, and there is a presence of the portal venous gas, then it is also indication for the surgical management. What are surgical options for the management of the NEC? There are two options for the management of the NEC. First is the exploratory laparotomy, which is a we can say which is a gold standard for the baby. It is a standard operation is laparotomy with the resection of the gangrenous bowel and enterostomy formation, and surgery can be resection with stoma formation or resection with the primary anastomosis. And it is a very important to differentiate with the SIP. It is a because SIP is a very good prognosis factor, and NEC is a poor prognosis factor. And the second option is the primary peritoneal drainage. Surgeon mostly considered the PPD in the extremely low birth weight baby who are unstable for the undergoing surgery. So they prefer in the PPD in the NICU. There is a trial regarding the which is better than laparotomy or PPD. Which is popularly known as the necrotizing enterocolitis surgery trial. It is a NEST, which is conducted in the UK. Includes the extremely low birth weight baby in 20 centers, and RCT done on 300 babies. Found that laparotomy had an advantage over PPD with respect to the survival and better neurodevelopment outcome at 18 to 22 months of the age. And death or impairment occurred in 78% in PPD group and 66% in the laparotomy group. And NEST trial found that 74% in the infants initially treated with PPD requires later resection laparotomy. So surgical management, NEC finding on exploratory laparotomy, if there will be a focal perforation, then if patient is stable, then resection and anastomosis is done, and patient is unstable, then stoma creation done. If there is a multifocal, then if there is a viable distal bowel, then resection and anastomosis. If there is a viability equation there, then there is a clip and drop technique. And if there is a in between portion is good, then stoma in resection and proximal enterostomy should be done. If there is a total NEC gangrenous portion, then prognosis is very poor. What are the complications of the surgery? First and most important complication is intestinal stricture, which is the most common GIT complication and can be present up to 35% of the cases, which is mostly present in the left side of the left side of the colon, and it is mostly present at the junction of the descending and sigmoid colon on the left side. And indicators of the strictures are failure to thrive, there is a feeding intolerance, and bowel obstruction after surgical. And if we are suspecting the intestinal stricture, then contrast with X-ray should be done before surgery. And there is second most common complication is short bowel syndrome, which is associated with the 25% of the patient who are undergone the surgery. And if there is a 25%, 50% or 80% enteric portion is removed, then it will lead to the short bowel syndrome, which is associated with the repeated dehydration, repeated loss of the electrolytes, and which requires a continuous PPN even at home, and which is very poor, we can say that, prognosis. And there will be a bowel obstruction will be there. There is a stoma related complications such as the prolapse, dehiscence will there, stricture will be there, bleeding will be there. And enterostomy closure usually done after the first 2 to 4 months and more than 2 kg of the baby's weight. And there is a cholestasis which is commonly associated with the NEC, which in suppose a patient is NBM for the 14 days, then it leads to the cholestasis secondary to the prolonged TPN. And other some complications like in view of the growth issues will be there, and long-term neurodevelopment outcome will be there. So oral prognosis is mortality of NEC ranges from the 24 to 40% according to the stage of the NEC. But if there is a NEC totalis, then it will be 100% mortality. And there is a significant risk of the neurodevelopment sequels like cerebral palsy, motor delay, cognitive delay, language delay, autism, and growth issues definitely will be there on the which must be entertained on the follow. Thank you.
Okay, good. I think good, Ketul. You've got a very extensive presentation. You have, I think, covered each and every aspect. Nothing has been left. You got to the incidences, the prognosis. Very nice. One question: just a baby who's 28 weeks born. One baby is by LSCS and one baby is by vaginal normal delivery. Out of the two, which one of the baby has more chances of getting NEC and why?
In LSCS, there will be more chances of the NEC because of the dysbiosis of the enteral pathogenic bacteria, which leads to the NEC. So more chances of NEC in the LSCS.
Absolutely true. But can you name one bacteria which is in abundance in premature babies who's born with a normal delivery, which is considered to be good, which tops the taxa of these bacteria in premature baby?
GBS.
Can you name that one of the? Sorry.
GBS.
It is lactobacillus.
Yes. Okay, sir.
Okay. Right. Wonderful. So.
Thank you.
So nice presentation, Ketul.
Thank you, sir.
Two things were there in etiology. One is antenatal chorioamnionitis.
Yes, sir.
There in mother.
Yes,
that
sir.
Also increases the risk in NEC.
Yes.
And abnormal antenatal Doppler.
Yes, sir.
Right. That also predisposes at higher risk of NEC.
Yes.
Number two, in prevention strategies, protocolized feeding pattern
Yes, sir.
are very important, right? If we have fixed protocol, for feeding, like when to start, minimal enteral nutrition, how to proceed. That is another important part. Mother's own milk is very important. And one thing which you should have mentioned, that oxygen saturation targeting, that also sometime affect NEC risk, right? Like in the lower oxygen saturation group, 85 to 89%, risk of NEC and mortality is more, whereas 91 to 95% targeted SpO2 group, risk of NEC is less, right? So these things, and NEC bundle, as you have mentioned, if we follow mother's own milk, protocolized feeding regimes, judicious uses of antibiotics, right, and antenatal corticosteroids, these things, and probiotic depends on the situation, and these things taken together can, to certain extent, you can control the rate, the incidence of NEC, right? Yes, any
Dr.
questions?
Dheeraj has given a very precise summary, very golden points what he has given. So to be remembered, has covered everything in just very nutshell. That's wonderful. Although this NEC is a domain of neonatologists only, pediatric gastro is just Irani Shadi mein Abdullah Devana wali baat hai. But then it is, of course, yes. So nice.
Thank you so much, Dr. Ketul, for a nice presentation. And there are a couple of questions in YouTube. So please respond to them. I will take the questions. And if not, then our expert will enlighten us. Is it okay?
Yes, sir.
Yeah.
Okay. So the one question is, why NEC starts early in term babies and late in preterm babies?
Because of the feeding strategies, there will be because in preterm babies there is a rate of increasing in the feeding is more days compared to the term babies, and in term babies specifically present with the cardiac issues, gastroschiasis, and ischemic specifically, which is present in the early, even sometimes at the birth. So which leads to the early presentation of the in term babies compared to the preterm babies, because NEC is in preterm prominently seen in the preterm babies, and it is specifically seen after significant feeding.
Right. So you said that NEC is occurring in 15% of the term babies. I remember when you presented that incidence slide, right? So, and out of those 15%, you told us that who are the babies who are at risk for getting these NEC in term babies. Yes. So the baby with the Down syndrome or the various with congenital heart diseases. So we have to be very specific whenever we are talking about the term babies. They're already diseased, they're already with such a risk factor already present in them. And only those term babies, they are more prominent or more pronounced to get NEC. So those risk factors, aggravate the presentation of NEC in these babies as early as possible as compared to the premature babies. That is one of the answers which can be fitted into.
Yes,
right?
Thanks. So one more question about the role of probiotics. Which probiotics to use and its dose? I think we have discussed in detail.
That has already been discussed.
Yes. One more question is regarding when and how to restart the feed after diagnosing stage 2 NEC. I think what should
Ketul, you can answer that. Ketul, you can answer that.
Yes, mostly we are using, sir, if a patient is stable after 10 days and there is no significant green aspirate is there. If there is a green aspirate will be less than 10 ml per kg per day, and patient is significant in hemodynamically significant after 10 days, then we start 0.5 ml per every 2 hourly for 2 days, and then we increase the feed 10 ml per kg per day. And if there is no RT aspirate and there is no abdominal distension, then we increase the feeding to 20 ml per kg per day up to 150.
10 days, first of all. And secondly, the residual aspirates. The residual aspirates, which is a very important role in this. And then it is 0.5 ml per kg per day, not 0.5 ml. We start with 0.5 ml per kg per day gradually, and then you top of the increasing in a adequate manner. That
One more question for Dr. Mohit. There are
Yes,
two
sir.
neonates with same gestation of around 32-33 weeks and with a birth weight of 1.3 kg. One with a normal umbilical Doppler flow and another with a reversed and a diastolic flow. What will be the policy to introduce the feeds?
So the baby's already been delivered, or is it this reverse?
Delivered. Their antenatal Dopplers were abnormal.
Right. So the baby who was with the reverse diastolic flow, so I'm worried in case of that, probably because that is one of the risk factors which suggests that there are more chances of NEC in this baby. So I'll be highly cautious in starting the feed and will be closely observing the baby. It's very important because it's one of the risk factors. So you have to go for a close observation. That is why I enumerate all the risk factors beforehand whenever we are talking about NEC. So we know that there is a big risk factor in this baby. There was a reverse of diastolic flow, which has already been depicted earlier. Baby is being on now. I have to go under a close observation, instruct my staff since 33 weeker, you said 33 weeker is all right, and the baby birth weight is good. We will introduce feeds, gradually increase, and start observing for any symptom which is coming up. That is my criteria. Every baby is the same, but here, as far as care is talking, but here I'll have to give some extra efforts to this baby. That is that.
Very true. Close observation, strict monitoring, we can start.
Absolutely.
Sure. One more question is association of delayed cord clamping with necrotizing enterocolitis.
There is a study regarding showing that there is a delayed cord clamping prevents the NEC, but there is a no randomized control trial or meta-analysis showing the clear benefit from the delayed cord clamping. So there is some benefit, some people showing that it is a delayed cord clamping leads to prevent the NEC, but there is no strong recommendation. But there are certain other benefits from the delayed cord clamping, but according to in less than 32 weekers.
So thank you so much. There are no more questions in YouTube as well. So anything from your side, Dr. Dheeraj and Dr. Mohit, to add? Otherwise, we can conclude.
Yes, I think it's also extensively discussed. Very nice presentation. Good questions were put up by audience, and definitely Dr. Ronak is a wonderful moderator. So along with Dr. Dheeraj as one of our co-expert. So everybody, I think, is enlightened, enriched by this discussion today.
Yes, I request Dr. Kunal Ayat to have a concluding remarks.
Sure.
Thank you so much for the experts, Dr. Mohit and Dr. Dheeraj, for smoothly conducting this session so nicely and putting all your inputs. Wonderfully presentation by Dr. Ketul. Very well conducted, clear and crisp slides were there, and all the details were included very nicely. So thank you all. Thank you, Ronak, for conducting the session. Dr. Prashant is also here. He was traveling, so I had to and Ronak had to conduct the session, but usually he does the job excellently. So thank you all the audience for your attendance. I would like to thank Dr. Yogesh Parikh sir, Dr. Nehal ma'am, Dr. Somsekhar sir for being present throughout the session. Thank you all, and I think with this we conclude our session. Thank you.
Also like to take this opportunity to thank Yogesh Parikh sir, Somsekhar sir, and of course Dr. Karia to giving me this opportunity. Thank you so much.
Thank you, Dr. Yogesh sir, Dr. Somsekhar Nimbalkar sir, Dr. Prashant, Dr. Ronak, Dr. Kunal, my co-expert, Dr. Mohit, and I would like to congratulate Dr. Ketul for a wonderful presentation. And I hope there are some good take-home messages after your presentation. Once again, thanks everybody. Thank you.
Thank you everyone. It was nice to have one and all. And with this, we announce also that those who are watching, please register for the Western Neocon and see you on next Wednesday in Neonatal Pathshala. It will be a lesson from the experts.
Dr. Prashant, one request that registration link, please again share in the group so that we can.
Sure. I'll just
circulate.
Yeah.
Even we can circulate to our
colleagues. Sure.
Yeah.
So thank you,
To you,
Dr. Divakar sir and Dr.
certificates. Sorry, yes, sir.
Yeah, thank you, Dr. Divakar sir and Dr. Mohit. And Excellent presentation, Dr. Ketul.
Thank you, sir.
Thank you, sir. Thank you.
And support of Dr. Ronak and Dr. Kunal and Dr. Prashant. Always young brigade is there.
Yeah, we can end today's meet now. Yeah.